morning, Laura.
Yes, good morning. How are you
Good
all?
morning.
Good. How are
Great.
you?
Good.
Thank you for joining us today.
Yeah, so
Yes.
sorry about the time mix-up. Like when I'm doing different time zones, it's very confusing, especially when I had two in different time zones back to back. So right after you, I go to another online event, and it's like But I'm willing to
Oh,
do like a part two also if they needed more time. I'm so sorry.
oh no, no
Hey.
worries. So, do we have you until 9:30 today? Is that the time frame?
Yeah.
Okay. Okay. Christina, Rev, do we want to get started now? Do we want to wait a little bit? What do we want to do?
I know we have the meeting starting at 9, so I know more people are gonna join around 9, but I'm gonna go ahead and record the meeting. So if you guys are okay, we can go ahead and get started now.
Okay.
Perfect.
So how we can start is maybe like start introducing yourselves and give a little bit of a bio, and then we can get into the questions.
Okay.
Sounds
Laura,
good?
we'll let you start.
Okay. Okay, yeah. So I'm Laura Smith, and I started specializing in childhood apraxia of speech after my daughter was diagnosed with it in 2012. So yeah, now it's pretty much all I do. I live, eat, sleep, breathe apraxia.
I love that.
Wow.
Very nice. Well, I'll introduce myself. My name is Vanessa Guevara. I've been an SLP for what year am I on? 17 years. The bulk of my experience has been in the schools. This year I transitioned to working in a clinical setting. And so that's me.
Okay, nice to
Nice
meet
to
you.
meet you. Nice to meet you.
I'm Janine Laguzzi. I'm also a speech language pathologist, and I've been in the field for about 29, 30 years. I'm not counting anymore. So I've been around for a while, and started with adults in a hospital setting and then moved to pediatrics about 17 and a half years ago when it kind of aligned with me having kids and being able to bring my kids to work. So loving
Nice
every
to
minute.
meet you. Yeah,
Yeah.
awesome.
Christina, your mic is off.
Mike.
I always forget that. Good morning, everyone. My name is Christina. Laura and I met a couple weeks ago when we had our first meeting. I am an SLPA at Speech Improvement Center, and I will be going into my 7th year of practicing as a SLPA next month. So really excited. Really excited to be with you guys with so much experience and learn from you guys. So I'm excited.
Nice to meet
Yeah.
you.
Thank you. And fun fact, when I started my program at Pasadena City College, my very first event that I went to, it was an apraxia event, and that's when I fell in love.
Wow.
I had no idea what apraxia was. Like this was my very first semester, Pasadena City College, and I remember getting the CASHA workshops. And they're like, oh, apraxia treatment and assessment. And I was like, I have no idea what this is, but I love networking. I love doing this. And since then, I fell in love with apraxia, and it has been one of my favorite uh, areas of speech. So I'm excited for it.
Wow.
So this
Yeah.
is why I'm so excited. I always tell people I see apraxia everywhere. So so thank you. Thank you for
Yeah,
doing
that's a fun story.
Yeah, it's one of those things that I think all of us, I know speech sound disorders is kind of like my jam, and that's something that I really love working with. And apraxia is always that popular term, right? That always comes up, and we're always like, what do we say? Do we diagnose it? Do we not? And it's always like
Yeah.
this. So we're so like happy to have this opportunity to be able to ask you questions. And we actually came up with a few questions just to go over kind of all the areas and get as much info as we can from you. So
Oh, perfect. Okay.
yeah. All right. Christina, do you want to get
Yes, of
go
course.
ahead?
So, I think the very first one, and I think a lot of people, we do have different different students or clinicians at different levels. So I think the our very first question is, what is apraxia?
Yes, so our formal definition is just childhood apraxia speech is difficulty planning and programming the movements for speech. But if you ever have worked with a child who has apraxia, it is so much more complicated than that, and so many things go with it. And even if you get them to a point where they are mostly intelligible to the average listener, there is still internal things that will be happening to them under different situations that we only now know because adults who have grown up with the label of CAS can now tell us what they experience as an adult. So yeah, I think that definition is so limited and hopefully will be expanded, the more research comes out with the adults.
For sure.
Yeah.
Our next question is, how do we determine if it's, childhood apraxia of speech or like a severe artic phonological disorder? This is going to kind of go into our next question, which is like common signs and symptoms, but yeah.
Okay. Yeah. So I think that one thing I learned when I did all this training for apraxia that I didn't know before I had it was that you can have both and frequently do have both. So it adds to the complexity of the diagnosis, right? Knowing that you can have both. So I think what differentiates apraxia, the ASHA-3 right now says that, so ASHA it's called the ASHA-3. So the three characteristics that ASHA says is a must-have to get a diagnosis of childhood apraxia speech is 1, inconsistent errors, and this is on repeated production of words. If you can't get the child to participate in a dynamic motor speech exam where you're like, say tomato 3 times, tomato, 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 then you can also do like, I do it sometimes as a speech and language sample where I take note like, oh, they said like, let's say the word pig. I heard big. Oh, I heard pig. Oh, I heard, and I can do it that way too. And, kind of observationally see inconsistent errors, but that would be number 1. Number 2 is difficulty with co-articulatory transitions. And essentially that just means articulating from either one sound to another, one syllable to another, one word to another. And when you're doing your assessment, it's our job to figure out basically where their zone of proximal development is. Yeah, like I will see therapists like, oh, well, I did a motor speech exam and all the errors were consistent, but they only did like a CV word or a VC word. So you have to find where the child's breakdown is. And so a great example of this would be when I had Ashlyn diagnosed with dysarthria. I knew she had my daughter's name is Ashlyn, who has apraxia and dysarthria. And she was 5 when I took her to see Ruth Steckel, who's an apraxia expert, but also was familiar with dysarthria because she worked at Mayo. And she came to Denver and I begged her to see Ashlyn. And so like a crazy mom, she let me, and I went to her hotel room and she did a motor speech exam. And I was like, I wonder what she's going to do, because Ashlyn at this point, like, I feel like her speech sound errors were pretty consistent. She was pretty intelligible. And she started off slow, like with words like bunny, hippo, and Ashlyn's nailing it. Bunny, 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 And then she progressively got longer and longer, and it ended up with microscope, stethoscope, statistical, and having her repeat those words 3. Oh man, you saw the whole breakdown. So I like to say, like, kids with phono, let's say you gave them a word like microscope, they might have a severe phono disorder, but it's still going to have the same stress patterns and be mostly consistent. So let's say their interpretation of microscope is microtope, and they're going to have that same stress. Microtope, microtope, microtope. Like, it might be wrong, it's pretty severe for people who don't realize what they're saying. But whereas with apraxia, you're going to see those difficulty with co-articulatory transitions. You might see revisions, hesitations, pauses. You can almost see their wheels turning, like, what in the world? Like, how am I putting those sounds together? So that can really happen at any level. That might happen at a kid at a CV level, at Ashlyn's stage of the game, that was at that multisyllabic level with complex clusters. So yeah, and then the third criteria of the ASHA-3 is some sort of prosodic disturbance. So I don't have to explain what prosody is to you guys, but I would point out that one thing we don't think about a lot with prosody is modulating your volume. So that's not something I tested a lot. So seeing if they can go up and down, or they can be loud and quiet. that's very hard for a kid with motor planning, and I never thought of it before I took all these trainings. So, and mostly with prosodic disturbance, usually what we see is syllabic stress issues, either equal syllabic stress or wrong syllabic stress. That's usually what we see, but important to keep in mind all those other prosodic disturbances can come into play.
Very nice. That was great information. Yeah, definitely differences, right? There's definitely things that will stand out to us. And
Yeah,
Shanine,
that
I think
is-
that was the next question, right?
So I think we wanted to find out a little bit about, like, are there any common signs of apraxia? I know when I'm looking at kiddos that have apraxia, I notice that there's a lot of difficulty or groping and like visual, like just visually looking at them, they struggling a little bit versus the phono kids that are, kind of just going through and saying what they can say. I don't know if there's any other common signs that you see just when you were looking at the kids and talking to them that are pretty common for apraxia.
Yeah, so Edith Strand has this great article in ASHA, the ASHA Leader. Pretty sure she put it out in 2017, and it's discriminating like characteristics that are becoming the most discriminative of CAS, because you might see, these characteristics overlap with phono versus CAS. And in that article, and then, in some research since, groping is absolutely included in that. You don't typically see kids with phono grope. Groping can also be a head nod as they're trying to get it out. So that's like, I like to just point out odd ones that I see, because you might not even realize that, we know the typical groping of the mouth, but I've definitely seen like them nod their head and attempt to like get the words out correctly. Vowel errors are more discriminative of CAS, particularly with diphthongs, putting those two vowels together. You might see a lot of errors with that. Inconsistent voicing errors are discriminative of CAS. So, just like that example I was giving you of like the pig, that'd be really common for them to go back and forth between pig, big, pick, all those different voicing errors. Let me think, what are some others that are more discriminatory? I have a whole sheet. So there is the ASHA 3, and other researchers in the field you don't use the ASHA 3, actually. They incorporate the ASHA 3 into their criteria in the research when they're diagnosing apraxia. And what they want is 5 different characteristics of CAS over 3 different speech tasks, which I think is interesting. So, because other researchers in the field do just straight up use the ASHA 3 to diagnose, but others don't. So, looking at all of those, pausing, excessive hesitation, that kind of goes with the coarticulatory transitions of, number 2 on the ASHA 3. Definitely prosodic disturbance follows more with apraxia rather than phono. I would say those are the biggies.
Okay, great. That's awesome.
Yeah. And our next question to you, Laura, it's kind of a big one. This is something that I've always been curious about, especially when we get questions from parents. Apraxia and autism spectrum disorder. What is your take on it, especially when our kids are non-speaking or minimally speaking?
Yeah, it's so interesting right now as it stands from a research perspective is we have a Schreiberg article who he only really looked at CAS, like that's pretty much like what his jam was, and his conclusion was it's very, very rare. I can't remember the exact number he came up with, but it was like almost non-existent, because how he was, I think, defining CAS, he was seeing different. Schreiberg is hard to read, you guys. He has a whole reason why he doesn't think that the kids who have motor planning with autism is the same as kids who have CAS without autism. And whatever, the result was, though, that he says no. But then you have a Tierney article, and Tierney worked with both kids with CAS and autism, and I'm pretty sure her number was upwards of like 65 or 75% of kids with autism have apraxia, and the CAS community rejects that and basically says that her information was flawed because she took subjects who already were at like an autism clinic, like that was her test, her participants. So I don't know. I can tell you from a clinical perspective whether Schreiberg was right and that these kids with autism don't have true CAS in the sense that he identified it as, the principles of motor planning still work, and they work really well on kids with autism who seem to have those motor difficulties. When they're nonverbal, though, there's a lot of things with autism, though, where, and I've tried to see it from the whole gamut. If they're dysregulated, you cannot do apraxia.
Yeah.
No matter how much their parents want me to, I can't. That basically what I'd be forcing them to do is behavior modification, or like ABA, which we all know is not neuroaffirming anymore. So I'm like, I can't in good faith do this. Like, your child needs to be like regulated. I don't want to dysregulate them more by doing this type of therapy. But there have been some kids, it's really been nice. I have a clinic, and I have a lot of friends who specialize in AAC here in Denver who have their own clinics. And there is sometimes that, and I only work with AAC like from a supportive position, not a teaching position. And so there are some times where they see these kids and they're like, okay, they're really trying to imitate letters. They're really trying to imitate sounds. And when they see that, they refer the kid to me and like, just see what Laura can do. And it's really interesting because if they are at that space where they're regulated, they understand, they can hold somewhat attention and participate, these principles of motor planning work for them. So that's what I would say.
Thank you. That's really great information. So controversial, right? Yeah.
Yes.
Thank you, Laura. Thank you for all that. My next question is something that I've experienced a few times, well, a couple times with some of my patients, and it's the suspected apraxia and tongue ties. How do you like? Yeah, explain that a little bit, because I've gotten a few patients that have a tongue tied and they have a suspected apraxia diagnosis. So parents a lot of the time say, well, do I have to take them in for surgery? Do we do apraxia treatment? Like, what do we do? Like, what's your take on that?
So, I mean, this is another like super controversial topic. I mean, I think that like, I feel like the research is kind of, in my opinion, out to lunch on this, because I mean, I know there's research that says essentially if you clip it, it can grow back even thicker than before. Since I've been in an SLPA myself, we call it SLPA here. Back in 2004, I remember my supervisor saying, if they have enough movement to make it to the alveolar ridge and say a t, we have enough movement for almost everything. And so I tend to agree with her. I did have one girl who had a obvious tongue tie to me. And it had that like, I mean, she couldn't even stick it out. And I did feel like that was impacting her ability to say those sounds, those alveolar sounds. And mom had her tongue tie clipped at 16, and she said it was the most painful thing she ever went through, and she would never put her daughter through it, no matter what anyone told her. Like, she would rather her daughter just speak differently than have to go endure that. So I don't know, like, she seemed to have a very traumatic experience. I know that like people I follow, like if you're on social media, like Amy Graham and pediatric, what's her name? I can see her face in my head, but she does all like pediatric feeding, and both of them, even in that regard, don't recommend really tongue tie clipping. So I think from a CAS position, yeah, if they're able to say all the sounds, the thing is that CAS starts in the brain. It's a neurological planning and programming problem. It doesn't start in the mouth. It's not an organic or structural problem. So if we operate under that assumption, whether the kid has a tongue tie or not, if they're stimulable for all those different sounds, then clipping it is, I mean, it's not really going to make that much of a difference. So I have had a mom against my recommendation, and she's a very good friend of mine now. I've been seeing her son forever. I feel like he's about to exit, but she did clip his tongue in the middle, probably 2 years into apraxia therapy. And I was like, the research shows it's like really doesn't help. And she was like, I know, but I'm not going to be able to convince my husband. He wants it done, so I'm just doing it. It made no difference. There was no difference like at all. So I mean, I didn't expect there to be, but yeah, there was no difference. Other kids, I had one kid and they clipped it and his tongue became so like floppy. It was almost like it gave him too much, and it was just like everywhere now. I was like, I mean, like, we still could work with it, but that was an interesting, and I've, in my whole time working with CAS, I've never, let's put it that way, I've just never seen a tongue tie clip be effective for treating it. And it really makes sense though, because it's a problem in the brain. If he truly was CAS, it's a problem starting here, not a structural problem here.
Great.
Thank you for that.
Thank you. Thank you.
Lots of
That-
great information here, really great information. So I know we're bombarding you with questions, but we
No,
have
it's fine.
we
I
have
kind of like
more.
it.
So I know this area is also really tough depending on what settings you're in, but who, in your professional opinion, who diagnoses apraxia? Like, I know like in the different positions I've had, speech has been able to diagnose it. And when I'm working in the company now, they want to diagnose through medical components. So in your professional opinion, like who diagnoses apraxia?
Yeah, I mean, according to the American Speech Language, according to ASHA, the SLP who has experience in motor speech disorders is the best professional to diagnose CAS. That doesn't stop developmental pediatricians from doing it. It doesn't stop neurologists from doing it. It's really quite remarkable, because the reason it takes an SLP is because we're the ones who can do a dynamic motor speech exam. No other professional speech therapists don't even know how to do dynamic motor speech exams for apraxia. I don't know what neurologists and developmental pediatricians think they have, but they do. Another example I can give you is when Ashen was at that same stage, I was kind of on a discovery stage. So she was 5 again. Got that dysarthria diagnosis. I was trying to see if I could find a cause, took her to neurology here in Denver. And like I said, she, for the most part, was intelligible. And she has a severe language disorder. So what she could say, she said, well, okay. Like she was very limited in her language. So yeah, we got that taken care of. I had a resident neurologist see her. And, we're looking at, I wanted to get an MRI and things like that. And you have to go to neurology to do that. And so she did her little exam, whatever. I have a 2.5-year-old running behind me being crazy, like in this room. And then the supervisor comes in, does her little exam, and then tells the resident, oh, that's a negative for apraxia. And I'm like in between trying to keep my son, like contained. I was like, wait, I'm sorry. Did you just say she doesn't have apraxia? And the neurologist doesn't even look at me. She continues looking at her resident and says, oh, was this the SLP, Mom? And the resident like nods her head. And she was like, okay. And I was like, do you need me to take you through a motor speech exam to show you? And she's like, still doesn't look at me and says, that's not necessary, and did not put apraxia in her report. So it needs to be us. It needs to be someone who has experience, but I do know limitations in the schools, and I worked in the schools for a long time. I don't even know how long, at least over 10 years, at least 15 years. And in both districts that I worked at, I don't think I was told explicitly not to diagnose it, but I knew not to. I knew not to put those words in an IEP. And instead, you just list all the characteristics and hope the next SLP is like, oh, this person was thinking CAS.
Yeah.
Yeah.
Yeah, I think that still very much
Right.
exists. We're supposed to use suspected CAS, but not
yeah.
actually fully diagnose it. Thank you so much for sharing some of your personal experiences. That's incredible I mean, crazy that was your
Yeah.
experience with the neuro.
Yeah.
Our next question is in terms of like the age of diagnosis, like when we have really young kiddos that we're not suspecting autism, but they're not imitating at all. They have minimal babbling. Like at what age can apraxia be looked at with these kiddos? Do they have to be at least 3? Anything
Yeah.
under 3?
I feel like it's a pervasive myth. There's this like 3-year-old number, a 5-year-old number, and an 8-year-old number. I've heard all of them. But the only criteria it takes to diagnose CAS is that they can participate in a motor speech exam. So again, like imitating words at least 3 times in a row, or at least verbal enough that you can get evidence of CAS. If they can't do that, you can still suspect it. And then ASHA does recommend you treat it as suspected, even if you do suspect it. Because, and this is important to note too, and it's not in the literature anywhere, which is unfortunate, but it's true. And I'm told everyone who works in this field of apraxia knows this. Principles of motor learning and approaches for apraxia work for all other sound disorders, but approaches for other sound disorders are not effective for apraxia. So We don't want to use an apraxic approach if they're not, because you can make faster progress. However, if you do suspect it, then it is prudent to move forward with a suspected diagnosis, because that will change the treatment. So yeah, I feel like things I didn't know because I worked in the schools for so long. I didn't work with babes, you know. So when I had Ashlyn, I didn't know all this stuff. So let me tell you guys, like, I take a more rigorous uh, case history report from parents now. And I even have them write it down, but I also interview them. Difficulties latching, super common problem in kids who have case histories of CAS. A lot of these kids will have had a tongue tie release because that was the problem with the difficulty with latching. So Ashlyn definitely had that. I did nurse her, but oh my God, it was a disaster. And then the lack of babbling. And then you have to like really delve in with the parents and explain the difference between what just might have cooing looked like versus canonical. Then did they have reduplicated? What ages did that occur? What, give them examples on what that looks and sounds like. So that is not something, I actually did not know that, but that's a lack of babbling can also indicate a language, developmental language disorder. So anyway, and then any oral motor things that might have been delayed. So like rounding their lips to pucker for a kiss. Blowing bubbles. Like I ask what ages they achieved all of those. Drinking out of a straw. When were they able to drink out of an open cup? Like any of those gives you more ammo to suspect CAS. And then even if you can with them, see if you can get them to do non-speech oral motor tasks with you. Can you round your lips? Can you retract your lips? Can you go back and forth? Let's be silly, you know, do stuff like that. Can we move our tongue side to side? Can you make your tongue touch your nose? Like, and if they have difficulty doing that, and you know, the complexities of speech are taken out, you're almost even more sure that like the cause of the speech problem then is likely due to motor planning. Also look at the whole body. Some kids like Ashlyn has developmental coordination disorder as well. And so like even when I was teaching her signs, all the signs looked the same. Ball, more, it was just two hands going like this. Like there was no like nice distinction between that. And then milestones. Like I remember they told me Ashlyn walked within a normal time, but it was 17 to 18 months and then she wasn't even walking well. Like that's not normal. That is not, that's delayed in my opinion. So, I mean, the pediatrician was still okay with it, but yeah, so if you see any like delays in other motor skills, I suspect it too.
That's great.
Thank you for that. Yeah.
Thank you. Thank you. All that information kind of brings back to a lot of our patients, a lot of experiences. So we're like, okay, now I'm like, you know, I always say this, I'm rethinking my whole life in a sense.
Oh, we all do it. I feel like we all do it when you learn more information. Like, oh man, like I had that one kid. Yeah, I feel like we all do that. The other one I failed to mention was pop out words. Different than autism, where it's like parents report language just seemed to stop. Language continues developing, but they might have said a word once or for a short time, and then you didn't hear it again. And like losing words is what parents will say, but not necessarily language development stopping. So that's another biggie. And that usually occurs as they're developing language. So by the time they have a lot of language, you're probably not going to hear pop out words anymore. So that's something to ask like early on when they were learning how to talk, you know, because normally if a kid gets a word, they have it. You're like, yay, he's saying mama now. Like, yay, he's doing this. It's very rare that then he did it and then it's gone, you know, so.
Yeah,
Very, very true.
Yeah. Thank you so much. Well, my next question is, now we're going to go into a little bit of treatment. So we have a child that has been diagnosed with apraxia. Now, where do we start? What do we do as clinicians? Like, what do we do with that has diagnosis?
Yeah, so I mean, I would really recommend if you're not familiar with any approaches for CAS, just becoming familiar with them. You know, I think the first one I started with was the Kaufman, now called the KSLP. She has like a video that I watched, I remember, and every training I got something out of, you know, like I've done prompt, I've done DTTC, I've done most of them, I would say. And I got something out of all of them. And the underlying thread though is that that, you're going to usually have a small set of functional target words that incorporate all the sounds in the child's repertoire involving a variety of syllable shapes that they are stimulable for. And it's going to be between 5 to 20, depending on what they can handle themselves. And it's going to incorporate different, I would recommend it incorporate different parts of speech. So frequently a treatment plan for a 3-year-old for me who comes in with limited speech and language might look like hi, bye-bye, mama, daddy, or mommy, dada, like just changing the syllable shapes there a little bit with the vowel change. Go, up, out, in, on. Those would all be frequent, because then once you get those functional words and you're using your cues and you're giving your feedback as per principles of motor learning, then as they get mastery of those words, then you start combining them, because that's the deal with apraxia is now, so good, you got mastery of the co-articulatory transitions between the sounds. Now we're going to say, bye-bye, mama, or go, daddy, or go out, daddy, go in, mama, and maintain, and you're holding them accountable for maintaining articulatory accuracy through the movement gesture. So yeah, the word list doesn't even end with that. And that's kind of, I would say, a common thread in most approaches, except for rest, but we don't really do rest here in the United States.
Beautiful. Thank you so much for that.
There are so many different treatment strategies and techniques. And I know with me over the years, I've just kind of combined some of them, like not just focusing, I think that that's pretty common practice, because you're trying to make what works for the kid, right? What would you suggest if somebody, like, I know we're getting some clinicians, maybe Kaiser or the medical field is diagnosing apraxia, but they're not sending over goals, and the slipper gets a report to start working with the kid, but they don't have any goals attached to it. Like, what would your recommendations be for starting goals, or how you address, I know this is a tough one, because it's like depends on the kid and what levels they're at.
Well, no, I don't think it's a tough question, actually, and I'll tell you why. I don't know how your clinics work there, but I've definitely had parents be like, "Oh, well, I got the diagnosis from Children's with my insurance, and I'm not in network with private insurance here except for Colorado Medicaid." And so they'll come and be like, "Okay, so can you just accept this report?" And I'm like, "Well, it depends on how the report was written, because an evaluation is not just for a diagnosis. An evaluation is to understand what goals are you going to do, what strategies did the kid respond to best." It was just like you said, like, what works for this kid. Unless the report is written completely detailed, which a lot of times it's not, like from Children's, the only information I have is the kid has apraxia, so I still need to do my own assessment. So I mean, I don't know how that works with you guys out there, but yeah, the parents seem to think that it's just the diagnosis we need. No. And like I just, to your point earlier, when you introduced this question, I love the idea that we are clinicians, not technicians. And that's the difference between what we're doing.
Yes. Okay, that's great. So you would recommend that we still going to go in and do our own assessments to determine what the appropriate goals would be for each kid, because they are going to be a little different.
Yeah, and if like the way it works with your insurance out there, however you have to bill it, or the parents, like out-of-pocket expense, I'll just do diagnostic therapy. That's what I call it. And I just do an assessment over how many sessions I need to get the information I need.
Perfect.
That's really great information. Thank you.
Yeah.
Another question we have, just in general, Laura, what would you say are some things that we should stay away from doing in therapy when treating kids with either a diagnosis of apraxia or suspected apraxia?
Negative practice. If you are getting negative practice is incorrect productions of a target word. And if the child, you just are not able to help them say a target correctly, just stop. Because all that's happening is you're just creating incorrect motor plans, and you're just ingraining it more and more and more. Another one, working on sounds in isolation. If you have to work on a sound in isolation because that's the only way you can elicit it at first, okay, but always think in your brain, the minute I can, I'm going to try and move it into a syllable shape. So like a common one is K. We just have to elicit K for some reason a lot of times. And if that's the case, you might have to work hard on getting it, but then I move it into a word like ick or ak, so it's at least being combined in a syllable shape. And a third one is if you're seeing overgeneralization, which is super common when you have when you're used to treating phono and you kind of resort back to your old ways, and I'm guilty of this as well, of being like, I think this kid can handle a phono approach now and we're going to make faster progress. if you have to always monitor what's going on in their speech aside from like a cycle or process that you're working on, because they can overgeneralize it. So if you decided I really need to work on final consonants with this kid, they will start putting in final consonants where final consonants don't belong. If you start seeing something like that, and I could go on example, stop, full court stop, like, and switch your focus from that. So
That is so, so important. Thank you so much for saying that. That's going to be so beneficial to all our therapists and to myself even.
yeah,
Thank you.
good.
Yeah, that was really
Thank you.
great.
Yeah. Thank you so much for that. I do currently have a patient, and that kind of fits all that criteria. So I'm like doing planning for him now. So thank you so much for all this information. I know we are getting really close to the end. So I know we still have a lot of questions that we want to ask. But we're gonna give right now an opportunity for the chat to go over some of the questions. So our first question
Oh, I
is
wasn't
going
even
to
looking at it.
yeah, so we have a
Sorry.
few questions from the chat from our clinicians. So the first one is how to cue GLP in CAS or slash cash and fleeing eye contact slash one look towards your face. How do
The
we cue
GOP
that?
thing right now is super hard, just because, I mean, we barely have research on CAS. There's none on CAS and GLP. Like, there's just not there.
Mm.
So this would be more from like a clinical perspective, but I can say that even if the child is a GLP, and I feel like I've had some, essentially what they're doing is jargon. It's just jargon. And if they do have apraxia, I still have to take them all the way back and do an apraxic approach, regardless of whether their language is GLP or not, because I can't just start at the phrase level if they're speaking in phrases, because I can't get the articulatory accuracy. I can't get the motor planning down. So I guess that's what I would say for that. Fleeting eye contact. I do a few strategies. Cards I feel like work a lot with kids with autism. So the Biorum cards, if you're familiar with them, I've got
Mhm.
so many different kinds of cueing, but I feel like they're more willing to look at cards. And a lot of kids with autism have that, special interest in letters. They already know their letters and letter sounds. You don't even need to use the drumming sound. You can just say D says, use your D sound, and then have a picture of the D. Or a lot of kids, like kids with autism, I found some of them really respond well to just mouth pictures. So you can find those on Teachers Pay Teachers, and like, use this M sound, and it's a picture of a mouth with an M. So that's what I do for that.
Beautiful. Thank you. Thank you so much. And then we have another question. Um, are there any trainings you have done and suggest that SLPs can do? I know we can do prompt.
Yeah. Oh, I didn't know Slippas can't do prompt. That's unfortunate.
Yeah.
But I would say that there's an Apraxia. Actually, the Apraxia conference, the Apraxia Kids conference this year is online. So it's expensive, but it's worth it. Like, you get to hear from the top people in the field, and then you can obviously pick your topics, and it's all related to CAS. So I think that would be really beneficial. If you email me, one of you, I can send you like Edwin Moss has a free Principles of Motor Learning PowerPoint on the Apraxia Kids website, where he at least takes you through those basics. And he gives you a PowerPoint with it, which I think is really helpful. Childapraxiatreatment.org has I don't know if Slippas can do it, but it has a free CEU training given by Ida Strand, and it's for CEUs, and that's also online. And that's an introductory course. And when you pass that, then you're eligible to go to one of her workshops that's in person. I think all those would be great. And then also you could also access Nancy Kaufman's video, I'm sure, without having to prove if you're even an SLP or not. So
All right, beautiful. And right now that you mentioned that's the person that made me fall in love with apraxia. So that's a
Nancy.
workshop I did. That's her. So now I remember her.
Oh
Her
yeah,
name.
she's very
Yes.
passionate. She is
Yes.
she's character. Yeah.
I know. I enjoyed her workshop. So if any of you guys want to do any of her videos, I know she does have some videos on YouTube and explaining some of the strategies. She's a great one to do too as well.
Yeah.
Yeah.
Yeah, I think we're all out of time, unfortunately. But Laura, you have given us such valuable information. Oh my gosh, thank you
Oh,
so
good. I'm so
much.
glad.
This will
Yeah.
be very
Yeah.
helpful to all of us.
Well, good.
Yeah.
I'm glad. It was nice to meet you all, and I do have to run off to another meeting, but yeah, it was. And if you have any questions, I mean, people always sometimes are like, "Oh, I'm so sorry to bother you," but that's why I do this. Like, you're not bothering me. I want all the kids out there with CAS to get the treatment they deserve. So I'm happy to answer any questions.
Thank you
Thank
so
you.
So
much.
much.
Thank
Thank you,
you.
Laura.
Thank
It was a
you.
pleasure having
It's
you.
wonderful.
And I know, and hopefully, yes, we can do a second part because we still have a lot of questions.
Yeah,
So,
I'm happy to schedule a
so
second
we
part.
can,
I'm so sorry about me and this time zone issue.
it's okay.
Yes. Okay, well, we'll
Sounds
be in
good.
touch. Bye, you
Sounds
guys.
good.
Thank
Thank you
you.
so much.
Bye. Thank
Bye.
you.